Okay, so I'm very happy to see so many familiar faces and names here. Good morning, good afternoon, and good evening, everyone. We are joining from different time zones, so I have to welcome everyone in a different way. Very, very warm welcome to our webinar. It's a pleasure to have you all with us today. This is an inspiring and educational session. I'm so happy to see all of you here. Many, many new faces as well, joining from different places and different backgrounds. So we're honored to be joined by Fotini and Mimi. They're executive directors of physical therapy Praxis, a leading physical therapy center here in Athens, Greece, with over 32 years of combined clinical experience in both the United States and Greece. They have been pioneers in introducing specialized physiotherapy interventions for pelvic floor dysfunctions in Greece, in Cyprus, and other countries abroad. They hold more than 50,000 patient cases and more than 300 lectures and training sessions globally. They have contributed very, very deeply in the way physical therapy supports women's health, especially here in Greece, and the musculoskeletal recovery with their groundbreaking programs, Mama, which in Greek means mother, and Pelvic Floor Act. Through their clinical practice research and leadership roles in the Pan-Hellenic Physiotherapy Association, they have actually shaped the physiotherapy landscape here in Greece, particularly in the domains of women's health and the sports rehab. They have been dedicated clinical lecturers and researchers at the University of West Attica here in Athens, and they both continuously contribute to academic and professional development. Their main goal is clear: to bridge science with care and to share their knowledge with physios, midwives, trainers, exercise professionals, healthcare professionals, to promote early intervention and evidence-based practice. Now, on the other side, for those of you who might not know about him, Antony Lo is an Australian physiotherapist with over 25 years of experience working at the intersection of musculoskeletal, sports, and pelvic health. He is the founder of M'a.M'a Education, an international educational platform designed to challenge traditional clinical models and empower health and fitness professionals to think critically and independently. Antony's journey has taken him from building two successful private practices in Sydney to traveling the world teaching his unique approach. He has invested heavily in continuing education and questioning the conventional teaching systems. Antony embraced a bold philosophy: do something different. This mindset has helped him guide professionals through transformative changes in their practice and supported clients ranging from elite athletes to everyday individuals. Antony has developed a practical and adaptable framework that promotes better outcomes by focusing on the person, not just the protocol. His mission is to help practitioners move beyond outdated methods and become confident, reflective, truly impactful in their work. So thank you for being here. This is going to be an amazing webinar. I can promise you that. I can see a lot of people still joining in. It's very, 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 how to say, exciting. I must say that you all should be able to have a translation at the bottom of the screen. You have to activate it by pressing the CC button. You can find it either at the bottom of the screen, or there should be a more options menu where you can find it and activate it. There won't be many options in languages. We can only translate from English to Greek. The other way around might seem funny. So if you hear someone speaking in Greek, don't look at the subtitles. It's going to be very funny. So only one way, from English to Greek. Now, there's going to be a question and answer session at the end of the lecture. However, you can use the chat box. I will keep track on your questions and we can address them all at the end of the lecture. I think I've said enough, and without further ado, let me present to you Fotini Lagari, Mimi Marcelou, and Antony Lo. Thank you. Mimi, you're muted. You're muted.
Okay, now you can hear me, right? Okay, and I was very excited to say welcome to today's webinar, and thank you very much for joining us. I don't want to take too much time, but I want to say that we're very, very happy to see so many people from all over the world to be joining this webinar. And it's actually great to know that we're joined by professionals from diverse fields. We want to know what you do and what is your title. You have told us already on the emails and stuff and on the forms, but it's great to know that we have healthcare providers, exercise professionals, physical education and sports specialists, midwives, trainers, and of course students. Each of you brings a unique perspective, and together we form a powerful community dedicated to advancing human function, quality of life, and holistic rehabilitation. So let me say on behalf of Fotini and myself, a special thank you to all of you, but also to Antony Lo, whose expertise, experience, and scientific insight elevate today's session. We'll see. You will be able to see it for yourself and hear it for yourself. He will give us the opportunity to deepen our clinical reasoning and practical skills, I am sure. So as we all know, documentation, evidence-based practice, and the seriousness, I would say, with which we handle the needs of those who trust us are essential to success and true contribution. Our hands and our guidance have the power to restore quality of life and promote a functional, active, everyday experience, which is a wonderful thing. And we're very lucky to be able to do that. So with this in mind, I now give the floor directly to our speaker, Mr. Antony Lo, so we may all benefit from the valuable knowledge he's here to say. Antony, the floor is yours.
Thank you very much. Thank you very much, Mimi, Fotini, Athanasia, and Kalamera, Tikanis. Now, I know that I'm supposed to say Kinezo Malaya Lenica, but I really don't know how to speak Greek very well. So I'm sorry. I know how to say things like kala, polikala, and, this is good. This is very good. Very good. All right. I just want to acknowledge the Bidigal people of the Eora Nation, who are the traditional custodians on the land on which I live and work. Pay my respects to the elders, past, present, and the future, and extend that respect to my fellow Aboriginal and non-Aboriginal colleagues. When we talk about female and woman, for me, female is about biology, woman is about the whole person. If I use the term female, it's assigned female at birth or cis female. And woman means identifies as a woman. And with that, I am going to try and move quickly. If I'm moving too quickly, can you please let me know to slow down? Just type in the message. I'll try to pay attention and we shall go from there. All right, I want to start by introducing Danae. Danae is a 34-year-old woman who is 3 months postpartum with her first child after an uncomplicated vaginal delivery. She's been on social media while she was breastfeeding and doing her pelvic floor exercises And she came across some posts about diastasis rectus abdominis. She's now concerned that she has DRA because she has some coning when she lifts her head when lying on her back, and is concerned that she might have pelvic organ prolapse as well because she hasn't been doing her breathing properly or doing her deep core activation exercises. She's avoided all other abdominal exercises just in case she was doing them wrong. And she spoke to her doctor about this, who has generously referred her to the physiotherapist. What would you do? Is this something similar to who you might see? So have a think about that. I'm going to start with some definitions. So, diastasis rectus abdominis muscle, also known as DRAM or DR or DRA, it's a separation of the rectus abdominis muscle from each other, especially under strain. It's caused by the damage or the fixation of the rectus muscle in their sheaths, and it's not an impairment of the linea alba itself. This is one definition from 24 years ago. A more recent definition says that diastasis rectus abdominis is defined as an impairment with midline separation of the two rectus abdominis muscles along the linea alba. So it's very difficult to say because even in the research, it's not clear. Now, the linea alba, it's a three-layered collagen structure considered the strongest element of the abdominal wall. It's a very strong structure. The interrecti distance is the distance between the two medial edges of the rectus abdominis muscles. So if you look on the inside of your six-pack, this is the width. And a hernia, by definition, is an abnormal protrusion of a viscus from one compartment to another. Or, in other words, it's a split, okay? So it's usually some sort of tissue tearing that allows tissue that should be in one place to be somewhere else. So these are all important definitions. It's important to note that a diastasis is not a hernia. The diastasis is the widening of that linea alba, that space. This is important to understand. The risk of life-threatening issues are very, very low with a diastasis. It's not very common. It's not like a hernia. There is a case in the literature of a lady who had a diastasis and she had a car collision, a very high-speed head-on car collision, and it still did not break the skin open, even though she had a diastasis. So, you know, it's very strong there. And lots of people, if you listen and if you ask, they will say that they're concerned that their guts are going to spill out and their abdominal wall will tear open. I don't think this is very, very common at all. You do see it in men, you do see it in children, and you do see it in people who've never been pregnant before. But the focus for today will be on people who are pregnant and postpartum women. The incidence during pregnancy, it's about 1/3 at week 21 of pregnancy, about 2/3 to 100% of people by the time they're ready to give birth at 35 to 41 weeks gestation. And then afterwards, roughly 2/3 will have it at 6 weeks postpartum, about half will have it at 6 months postpartum, and about 1/3 will have it at about 12 months postpartum. And depending on who you read and the research, it seems to decrease as, the age goes on, which I find interesting. Now, we know that it's not associated with pelvic floor dysfunction at 12 months postpartum, but it seems to be at an average age of 55 years old. Now, this is very interesting because how do you say something is causative? I don't think you can. This is not very logical, but it's an interesting thing. And so lots of people make up stories as to why. Interestingly, at 12 months postpartum, the pelvic organ prolapse incidence was higher in those without a diastasis compared to those with a diastasis. So basically 16% compared to 4%. That's nearly 4 times higher in people without diastasis. And the question is, well, why? the diastasis, it does seem to be associated with musculoskeletal pain in some studies, but the reasons are not clear as to why this happens. And so I think that maybe the reaction to the way that you have a diastasis or the way that it looks, or simply the diagnosis of diastasis, it leads people to behave in a certain way that might actually be making the symptoms of musculoskeletal pain and pelvic organ prolapse occur. Or maybe they were just going to have pain anyway, and in search for a cause, they say, oh, it's because of my diastasis. So if we have a look at Danae, she sees a physiotherapist who listens to her concerns and found the following. The 2-finger width diastasis, about 3 centimeters at the widest point, just above the belly button at rest, which doesn't change much during a head lift. So it doesn't get wider and it doesn't get narrower when she does a crunch. Danae has been doing some transverse abdominis exercises based on some social media posts she found and timing it with her breathing. There's no pelvic organ prolapse signs or symptoms, nor any pelvic floor disorders are noted on the internal examination, and her pelvic floor muscle contraction was considered normal. In other words, she can squeeze and she can lift, and this is considered within the normal range. There's some coning or doming noted on some head lift exercises, but when it was palpated, it was quite soft. No hernias were noted, and nor any symptoms reported by Danae. So what do you think about this diastasis size? What would you do because of a diastasis like this? So some more diastasis facts. Linear ultrasound is the most accurate way of measuring the interrectus distance. There's issues with calipers. Calipers are accurate, but if you've ever seen the calipers, they're either very pointy and sharp, which are very, like nobody likes sharp things, or they're very broad and plastic and wide, and they're very scary looking with the calipers. People use finger widths, but finger widths, my finger widths, I will guarantee you are different to Mimi's finger widths, okay? People can use CT and MRI, but they have challenges with this because of radiation and expense and accessibility. The cutoff point for normal, it does vary in the literature. So for people who have had their first baby, after their first baby, 16 millimeters at 2 centimeters below the belly button, 22 millimeters at 3 centimeters above the belly button, or 15 millimeters inferior to the xiphoid process. But is it fair to label postpartum women as having normal or not normal based on these values? Because if you have subsequent babies, I've not known anybody that gets less and less gap with each pregnancy, right? Like usually it's hard to hide the fact that you're pregnant the second time around compared to the first time around. So the cutoff points for normal continue to vary. There's some research proposed in the German Hernia Society and the European Hernia Society, which said that mild should be considered at 2 to 3 centimeters of the linear alba width, moderate be 3 to 5 centimeters, and severe be more than 5 centimeters width. Now, I don't agree. And part of the reason why I don't agree is that there's been other research that said, well, maybe up to 34 millimeters can be considered up to normal at 3 centimeters above the umbilicus. I think this is much more reasonable because, you know, calling 5 centimeters severe, anybody who's just had a baby, you could probably find people quite easily, and to tell them that they have a severe diastasis when they've just given birth, I think this is not very nice to do. So I am not concerned about any interrectus distance less than 5 centimeters. I would say mild is up to 5 centimeters. From 3 centimeters, 3.5 centimeters to 5 centimeters is mild. And then above that, 5 to 8 may be moderate. And then above 8 or 10 centimeters, okay, this is more of the larger ones. Now, this is some ultrasound here. And what I want you to see is that this is at rest, and there's a linea alba here. This is taken in a woman who was 6 weeks postnatal, at rest. And that's the rectus abdominis here. This is the linea alba here. And this is the rectus abdominis here. The skin is on the very top. And then there's the fat. And then there's the tissue there. And then underneath, this is the muscle. And then you're going to have your viscera under here, your internal organs. Okay? And then I want you to see what happens when you do a pelvic floor only cue. The rectus abdominis, it gets bigger, right? And then this can get longer or more taut. You know, people talk about a distortion index. If you can tell me the difference that you can see between here and this, it's not very different. It's not very different, okay? And then with a pelvic floor only cue, you can see here that the transversus abdominis is here, the internal oblique is big. There we go. So at rest, and then this is a pelvic floor only cue. But why is the internal oblique working so hard? So lots of people think that they're isolating pelvic floor, but I own the ultrasound machine that took these. And I can tell you that people are not isolating their pelvic floor when they do a pelvic floor muscle contraction. And you can even see here that the internal oblique is getting wider, okay? And then on an auto curl up, so what that means is we don't cue you, you just do a curl up. This is your external oblique, this is your internal oblique, and this is transversus here. Your semilunaris is here, and you can just see the edge of the rectus abdominis here, okay? So at rest, and then they do the curl up. See this? Look, it pulls into the midline. Even though the transversus, look how big the transversus gets. Look how big the internal oblique gets. Look at how fat the external oblique gets. And yet it still gets pulled into here. That's because rectus will shorten and pull. All right, this person, primiparous, so first baby, 3 weeks postpartum, I examined her. And so just to show you, at rest with a pelvic floor, at rest, and then the auto curl up. Oops, my fault. Pelvic floor, curl up. There's just a lot more muscle activity. But even on the pelvic floor contraction, you can see that she's getting internal oblique working. See, it gets wider. But not as much as a curl up because she's not moving that far. I thought you might be interested in some ultrasound there. Okay. Let's talk more about Danae. So the physiotherapist had taken my Diastasis Done Differently course and so began with the following. They demonstrated to Danae how strong she already was despite avoiding all abdominal exercises except transversus abdominis, breathing, and pelvic floor exercises. They explained that the research would consider her diastasis to be either normal or mild, but also said it can feel quite significant to Danae because Danae is concerned about it. So this is not to, you don't want to minimize what her experience is. It's to acknowledge that this is significant for Danae, but also that the research would consider this either normal or mild, even though her body feels very different. The physiotherapist showed Danae how she was already doing the exercise. She was already doing exercises, just taking care of her baby. So demonstrating with the baby or with a weight, just how carrying the baby can actually be working her abdominal wall. The physiotherapist told Danae to stop doing the gentle exercises because it's time to move on to the harder exercises, considering Danae wanted to do more and she was quite scared of doing more. The physiotherapist taught her about soft doming and hard doming and coning so that she can self-monitor, and started her on some simple exercises on her back, on her side, facing down, and in standing. Some more facts. There's no proven management to close the interrectus distance apart from surgery, and even surgery has its risks. So when people tell you on social media that they can close a diastasis, remember that 2/3 of people to 100% of people will have it when they give birth, and up to 2/3 will get better by 12 months postpartum, and they didn't do anything special, okay? So 2/3 of people will just have their diastasis improve just by doing nothing. Surgery has its risks, up to 40% recurrence rate. There's complications afterwards, including seroma formation, wound infection, chronic pain, and persistent loss of sensation. You can have numbness. Exercise, both general and specific exercises, abdominal binders, taping, electrotherapy, dry needling, acupuncture, manual therapy, taking supplements, all have no evidence or no difference on average compared to other things, or very low quality evidence to support the fact that they work at this time. We do know from research that doing an abdominal crunch exercise, because it used to be that you don't do crunches because you have a diastasis. Well, we know that it doesn't make a diastasis better or worse. It doesn't change the severity of any pelvic floor disorders or low back pain or pelvic girdle pain or abdominal pain on average in the people in the study. It does improve abdominal muscle strength, which is always helpful, and it does improve abdominal muscle thickness. And hypertrophy, I think, is important because if you're going to take up some loose tissue, having strong, thick muscles is a way to help with that. And just the process of developing hypertrophy will put tension in the tissues in a helpful way. So the risk factors for diastasis are pregnancy, including more and more children. So the more children you have, the more likely you are to have diastasis. If you have a cesarean section after 2 births, you're more likely to have a diastasis. BMI, so body mass index, and heavy lifting, there is mixed evidence on this. So some will say that it's not a risk factor. Other people say that it is. And I can tell you, as somebody who has a high BMI, that having visceral fat, visceral load, will stretch on that abdominal wall, and it might stretch it. But then in other people, it doesn't cause a diastasis. So we're unsure. It's mixed. Diabetes seems to be a link. And we think, blood flow and tissue quality is a part of that. Possibly prior abdominal surgery. So having an operation in the past may be part of the reason why you develop a diastasis. There is an anatomical variation where the internal oblique attaches to the rectus sheath posteriorly only. Now, this is very important because lots of people will say that you need to have transversus to pull taut there so that you can have tension across the linea alba. Well, the problem is that in this research, those who had the internal oblique attach only to the posterior rectus sheath. So it's like another transversus abdominis muscle. These people had more diastasis than people who had the internal oblique attach at the posterior rectus sheath and the anterior rectus sheath. And possibly inguinal or umbilical hernia, but many were males in that particular study. So you can't say that this is a risk factor for women. What we do know that are not risk factors are age. You can get this at any age. Your weight before you got pregnant, maybe. Like, how do we know? Right? Maybe they had it before they got pregnant. Maybe it's got nothing to do with it. We don't know. That's why it's a question mark. Weight gain during the pregnancy, the amount of weight that you gain doesn't seem to correlate. how you had your baby, whether cesarean section or vaginal delivery. It doesn't seem to influence the risk of diastasis. The baby's birth weight doesn't seem to correlate, but it will be interesting if we looked at, say, the birth weight and the mother's weight at birth to see if there's some sort of ratio there. That would be interesting, but I'm not sure how useful it is. Hypermobility, having hypermobility doesn't seem to increase the risk. And that makes sense. For some people, when they have more elasticity, more mobility, maybe they can stretch more without doing permanent damage. And then other people will say that having hypermobility means that it's more easily stretched. We don't actually know, and obviously it comes out as no increased risk. Heavy lifting. Some would say this is not a risk factor and others say that it is. I think the way that you do heavy lifting might influence if you develop a diastasis or not, but there's no evidence to say one way or the other that it's a guarantee. And then the level of postpartum and general exercise, level of postpartum general and pelvic floor exercises at 12 months postpartum does not seem to indicate a diastasis risk. Now, Alona has asked, can osteogenesis imperfecta type 1 make the recovery longer? I don't have this off the top of my head. I can look it up. It's not in my brain as something, but it doesn't mean that that's not true. So I'd have to double check that for you, Elena. Now, soft doming and hard doming. Twin pregnancy, multiple gestation. Hold on. Yeah, no, it's not here. But I suspect, Rachel, part of that is that there's probably not enough research done on it. It seems easy to say that, yes, having twins would be a risk factor for diastasis because of the amount of stretching that occurs, but I wouldn't say one way or the other. All right, let's keep going, hey? Soft doming and hard doming. Soft doming is where the linea alba is soft. If you're trying to tear something and we're concerned about making a diastasis worse, or we're concerned about developing a hernia, then soft doming is soft, okay? So what that means is that you can't tear your shirt until you pull it very taut, and then you can tear it. It's the same thing. So if your linea alba is quite soft, how can you be tearing it? You can't tear something that is not on tension enough that it feels hard. So I'm not concerned about it. So on Instagram, if you go, you'll find that I have some of this explained for you. So hard doming, I think is still okay, but I think it's just closer to stretching it and potentially doing more. So linea alba, it feels much softer, and you can push on the midline and feel the edges of the rectus muscle, and the belly button will be soft, okay? So if you watch here, so she's doing a double leg lift, she's doing a doming, this is Kerry, and it's quite soft. She is not going to make her diastasis worse because she's doing this, okay? This is quite normal. This is soft. I am not concerned about it at all. And skin and fat is not considered to be a diastasis. Just because somebody has skin and fat doesn't mean that they have a diastasis. It's about the muscle and the linea alba. Now, what about hard doming? Now, I tried to get Kerry to give me hard doming. She had to fake it, okay? She had to fake it. I got her to push out and make it taut. And even then, it was too soft. So I just asked her to touch gently. I want you to imagine that if you did a crunch or a sit-up or a hollow hold and you touched your muscle on the side, you know how hard your muscles are, If your linea alba is as hard as the rectus muscle, then I would consider this hard doming, okay? So again, Kerry is faking this. So it's as if she's pushing and she can't push in, okay? Hard doming. We can't even get her to fake a hard doming, okay? That's how rare it is. It's not that common, but lots of people are very concerned about doming. All right. Danae came back about a week later. She reported the following. The information was quite confusing at first, but she went to Antony's social media, which had lots of different education videos there about diastasis, and she began to understand things a bit better. She started doing exercises, and she was concerned about some soreness around the abdominal region about 2 days after the appointment. So she stopped exercising until the appointment because she was concerned about this soreness. The physiotherapist assessed and assured Danae that there was no further damage and the soreness was likely to be DOMS, delayed onset muscle soreness, because she hasn't done much exercise for months now. She's just normally sore from not having to do exercise for a long time and then doing it. Danae was very relieved, and they went over the exercises again to make sure that she was doing them in a way that was not likely to be making anything worse. So some more facts. Intra-abdominal pressure does slowly increase with each week of postpartum. We know this from the research. We also know from the research that a diastasis, on average, will get narrower each week postpartum. Now, those with diastasis, they have less incidence of pelvic organ prolapse, and a more recent paper showed that they have a less incidence of stress urinary incontinence as well than those without a diastasis. Interesting, huh? So, what if a diastasis is actually a protective mechanism so that the perineum and the pelvic floor can recover in the early postpartum period so that you don't develop pelvic organ prolapse, stress urinary incontinence, or any other pelvic floor issues? I think that being able to stretch more in the front will mean that less pressure goes down. I think this is a good conclusion to consider further research, okay? So the challenging question is, if diastasis happens to nearly everybody who's been pregnant, is persistent in 1/3 of cases, is not immediately associated with pelvic floor dysfunction or musculoskeletal pain, but it may be later, which might be due to an altered behavior from the aesthetic appearance or the diagnosis of diastasis. So they don't like it, so they do things to pull their tummy in, which might be the reason why they're developing symptoms. If diastasis doesn't limit functional ability or their strength or their performance, but the person doesn't like the aesthetic appearance, and the insurance companies and the government-funded healthcare, they don't pay for cosmetic surgeries. What if we are making this condition to be considered to be a bad thing so that abdominoplasty surgery can be improved? This is a thing, right? This is a thing. I think that this is a possibility. What if you say that it's bad? Because if you want to have a tummy tuck and you say to your friends, oh, I'm going to have a tummy tuck because I don't like how my belly looks, some people might judge you. Oh, why are you so worried about this? Whatever, right? They're allowed to be concerned about it. But if you say, oh, like I have to have this special operation because the doctor and the physio said that I'm going to have bad pelvic health issues later on in life and I better have this done now, your friends will say, oh, good on you for doing this, taking care of yourself. Yeah. I have issues with bad reasoning being the reason why we do things. I don't know the answer. It's certainly possible that maybe this is an agenda. So at the end of the day, meet the person where they're at. So wherever they're at, no matter what they're feeling or how bad things are or not, meet them where they're at, help them achieve the goals that they want in a biopsychosocial way. So consider the whole person and what they want, not just what you want, in an ethical, empowering, and supportive way. I think that's what we should do. Danae's story. We'll finish on Danae's story. She went on to do more and more exercises, and she gradually improved her strength and fitness as well as how she looked. Her diastasis width didn't worry her anymore, and she went back to doing regular exercises over the coming months, and the diastasis was no longer a problem for her. So, my questions to you are, what concerns do you have for Danae? What would you do differently? What if her diastasis was the same width, still 3 centimeters? Are you concerned? Are you not concerned? What if her diastasis increased in width? Would that concern you? All right. I just want to quickly go over what is in the Diastasis Done Differently course. So you can do this in person or you can do it online. Everything is obviously online. But if you have any questions and answers, you can only do it via comments. You put it in the comments and I answer the question there. If you want feedback about your own technique and skills, you can only do it by booking a session with me online and I can check the video, we can discuss things, okay? You get everything else in the live course. However, you get to ask your questions in person, live. Also, when I come to Greece, I will have my ultrasound machine with me and I'll be able to show you on you. And I like to work over lunch. I'm happy to work during the breaks. I'm happy to image people to show them what's happening with their abdomen and their muscles, okay? You'll get a real consult to watch from start to finish, a 1-hour consultation so that you can see what it's like. Online, you get to see them, but in person is different, right? You get to watch it. So everything is there for you live, and you get live feedback and ask your questions and get your answers answered then and there. So I really encourage you to come in person, where I'm coming October 11 and 12. And thank you to Physical Praxis for hosting me. They're going to send you a link, so please make sure that you keep an eye on your email for that. Otherwise, this QR code will let you, if you're elsewhere, if you're not in Greece or you can't come to Greece, you can find via that link elsewhere. The places will be limited, so please book in quick if you're interested in doing it. Now, for those who have done the course before, we do have a discount, but there are only very limited places for this discount. We're expecting this course to go well. It's very, very practical. It's 2 days of lots of movement. This is the longest type of lecture that you'll get on the course, okay? So please contact us and be sure to mention PT Praxis webinar when you do. Otherwise, I have the Q&A time now. I'm happy to answer any questions, so please feel free to ask in the chat. You can work with me. You can work with me. I help people. I can either see your clients or I'm happy to do mentoring. I can do lots of different things here. My contact details are here. And yeah, but otherwise, there we go. Otherwise, just a reminder that this is what we're doing. And thank you again, of course, to Mimi, Fatini, and PT Praxis for hosting this webinar. Thank you to Athanasia. Yeah? Athanasia. Thank you very much as well for all the admin work that you've been doing. Please remember to mention PT Praxis, and we'll organize, if you join the course, we'll organize a current concepts webinar for you. Okay, so thank you very much. I'm happy to answer any questions. I can see there's a question now from Rochelle. My
Sorry,
take on
Anthony.
hyperpressives. Oh, yes.
Sorry, there was an earlier question from Ilona. Can
Yes, I
osteogenesis
answered this.
imperfecta, for osteogenesis imperfecta?
Yes,
Okay, sorry,
I
I
said
missed
that I'd
that.
have to go look it up. It's okay.
Sorry, I missed
It's
that.
okay.
So we're going down
It's
to
okay.
Rachel again.
To Rochelle. Rochelle in the hyperpressives for diastasis and pelvic organ prolapse. Look, my take is this. Hyperpressives is no better or no worse than anything else that you can do. This is what the research would indicate. I think for some people, it will be amazing for them. For other people, it will be a waste of time and money for them. Just like doing anything else. You can tell me anything, Pilates, you can tell me going to CrossFit, you can tell me going to the gym, seeing a personal trainer, buying a program. It's going to be great for some people, it's going to be not great for other people. And so this is where I am with hyperpressives as well. I haven't seen anything convincing that it's going to help a diastasis more than anything else. Any other questions? Or tell me what you think.
Please feel free to raise your hand or unmute and ask questions. Or
I'm
maybe
not
you
sure
can
they can unmute
place them
on
in the
their own.
chat.
I think your host settings are such that you can't unmute. So you
I
have
can
to raise your hand.
unmute them if they raise their hands.
There we go.
Yeah, we have one here.
I don't know how to read Greek, I'm afraid. I don't know this person's name.
Yeah, Krisa.
Hello.
Krisa? Hello.
I'm from Veria, Greece. So
Hello.
I'm actually having a surgery programmed in the end of June. I have diastasis. I'm about 4 to 5 centimeters. So I've been having trouble. I have been having pains. I'm a bit I'm scared a little bit.
Yeah.
So,
Okay.
and after the surgery, the physiotherapy, the amount of, I don't know the word, I can't remember the word.
If you say it in Greek, I'm sure someone can tell me. Okay.
Το ασκησιολόγιο της φυσικοθεραπείας.
The exercise protocol.
Oh, the exercise protocols. Yes. We keep it very simple. Thank you, Krisa, for your question. I can't give you any specific information about your condition because this is unethical to do so without a consultation. But in general, what I'm looking up right now is that I have some links to a panel that I recorded. And so let me just try and find it. I don't know why I can't find it. It's 3 hours of video. Here we go. I'm going to put it in the chat here for you, and you can watch it, and you can see what you think. And there's 2 sessions, session 1 and session 2. And they talk about the preparation for the surgery and what happened afterwards, okay? What happens afterwards? Like I said, I can't give you any specific information. Every surgeon has their own protocols and what they allow you to do and not. But I can tell you that I work quite normally with people after this operation. I'm usually quite conservative. We take it nice and easy, and slow is smooth. Smooth is fast. Okay? And that's how we do it. It's not very different to many other things. I hope that answers your question for you, Krisa. Mimi, you've got your hand raised, so you might have to unmute. Thank you.
Yes, you're ready to go.
Antony, we treat patients with pelvic floor dysfunction the last, I don't know how many years now, and diastasis was always an issue.
Right.
Could you please give us your knowledge and experience traveling all over the world? What is happening with the diastasis right now? We do talk about it a lot in Greece. We have patients coming to our office from physiotherapists, other physios who don't know how to treat diastasis, midwives, exercise physiologists, and there is a bit of confusion, and that is what we try to create, to introduce in Greece. All of us, we have a role. We have the rehabilitation that midwives have to identify as soon as after giving birth or during pregnancy. And the exercise therapists, they have to know how to protect and, of course, to maintain. What is happening all over the world? What is happening in your country? What is happening in the United States that you're traveling, and in Europe too? Could you give us a picture? Because we're trying to grow this issue in Greece.
Yeah, look, awareness of it is important because I have never met a person who truly does not care how they look. Because I say to them, all right, they say to me, I only care about function. I just want to do things. And I say, okay, you don't care how it looks. And then I say, what if I can get you back to doing everything you can? Do you want to also have a flat stomach or not? And then they go, well, of course, I would rather have a flat stomach than not a flat stomach. Do you know what I mean? Like everybody does care. So I think a lot of it is fear. I don't think there are any serious conditions that come from it. And in fact, I think what's happening that I've seen is that people focus far too much on diastasis. They make it too big a problem. And so then people become scared to do anything. And then people start bracing and sucking their tummies in. And I think there's a certain percentage of people who do that, who then put downward pressure on the perineum. And then they start having pelvic floor symptoms. And then people tell them that their core is weak and their pelvic floor is no good. And I think that medicalizing it and making it worse is not helping. So around the world, I see some people, they don't care at all. And I don't think this is right. I don't think this is right. And then other people, they care too much. Like I see some people that have classes and they lie them down and you have to breathe properly before you can progress onto the next exercise, isolated contractions. And then they lie there and they have to do these isolated contractions and they do their bent knee fall. It's a very gentle exercise. And these people are postpartum. What if your exercise class is 1 hour of them lying there, doing nothing, having a rest, and this is the thing that helps them recover, rather than running around taking care of people, because they ran around to take care of the kid so that they can come to the class. They come lie down and do your gentle exercise for a little while, and then they're going to get up and they're going to run around and do everything else that they need to do that day. Do you know what I mean? Maybe the class is helpful not because they learn how to breathe and to contract and all the rest of it. Maybe it's helpful because they actually get a rest. And so around the world, I see a lot more anxiety about diastasis and not enough reassurance that things are probably going to be okay. And what is more important is not how much your belly moves, but actually, are you bearing down when you're doing things? Because I think this is more the problem. People in trying to have a flat tummy will start to bear down and develop issues that they didn't have before. And this is what I see a lot of.
If I may say something also, I agree. I totally agree with you as far as the what we think is going on as compared to what we really know that's going on. And the knowing and the knowledge goes both ways. It goes to the teacher, the instructor, the know-how person, transfer the knowledge, and also to the person who will receive the message. So first of all, it is us, all of us from all different areas of expertise, as Fotini said, and I said at the beginning, physiotherapists, midwives, exercise specialists, trainers, whatnot. I mean, and all the people who are just learning now, we need to know our stuff. And we need to know what the rectus abdominis is doing, and we need to know what the transversus is doing, and we need to know how these muscles are incorporated along with the diaphragm and the pelvic floor to do something safely. And this is something that you will probably elaborate on when you come to Greece. And it's very important for people to understand it and put hands on the area so that they can understand this. Because if we do not know that the rectus abdominis is doing A and the transverse abdominis is doing B, then let me tell you, we cannot rehab anything. And we cannot certainly touch the diastasis. So we are just pretending we know it, and, we're not knowing it. And then, we will just offer more fear, more stress, more agony, more insecurity, and more not knowing anything, but, just come pay us and we will just tell you to do the wrong thing. I'm not happy with this. And this is why we're opening up this kind of pathway to you, Antony, because we're people of science. We're people that are bridging clinical practice and science and therapeutic exercise, and then flying freely to exercise and do your best and what makes you happy kind of thing, because people need to be happy and improve their quality of life. And there are a lot of mothers that are staying at home without going out there, doing what they like most. And this is exercise, dance, being happy, do things with their kids, and blah, 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 blah. So, we are just opening the pathway for people to learn evidence-based material that they will feel strongly about, and then they will just go off on their practice or to their gym or to their hospital or whatever it is, and, create a frame of good quality work in order to rehabilitate and in order to improve the quality of life of these women. Because when you know what you're doing, then you can tell them without any fear and without any stress. And then they will trust you and they will make sure that they do what you tell them. I don't know how you feel about that, but I think that this is the most important thing.
I think you're right. I think if we don't know what's happening, then this does not help, because we're either telling stories or we're creating fear or we're just guessing. And the most common feedback that I get when people come on the course is they go, oh, I thought this was happening. And then I can show them on the ultrasound, and I can show them with the testing that I do, and I can show them with the exercises that I teach, that, oh, maybe what you thought was actually not what was happening. And so this is the most exciting part, right? Because people get to experience the learning and what is actually happening, and using the ultrasound has been very helpful for that. There have been a couple of questions. So which is the profile of the patient that that should have physiotherapy sessions, but also is not a clear suggestion for surgery? Look, I am biased. I'm a physiotherapist. I think ideally everybody should at least have 1, maybe 2 sessions with a physiotherapist after giving birth, because you're going to learn so much more than just diastasis. For me to check a diastasis, it takes like 2 minutes. It's very quick. But I also check their pelvic floor contraction. I check how they're doing things. I teach them how to carry the baby, how to pick up the baby. I make sure that they can do 15 kilos of weight, because this is how much a pram or the baby carrier is. So they have to be able to do this if they're going to help move their baby around. So I teach them these things. So that's number 1. Number 2, who are the people? I think the larger the diastasis, the more likely it is that it will struggle to get back to normal. I think people who do exercise in a certain way, the ones who do transversus work, I think those people, I find people who do transversus work, they're harder to change what's going on. So yeah. And then what about suggestions for people who decided to have a surgery before and after? What's the difference with the rehab for someone who just had diastasis but will not have surgery? The difference is that I respect surgery. So if somebody has just had a surgery, you can't work them too hard because you're going to tear the stitches and the healing, okay? But otherwise, it looks very similar, just the timelines are different. So Evangelia says, thank you for the talk. I would like to ask if there's a difference in diastasis when a surgeon puts dissolving stitches at the rectus while a cesarean section. Thank you. I don't think there's a difference with dissolving stitches and permanent stitches. From what I understand, there's a number of factors such as genetics, the tissue thickness and quality, and the dissolving stitches don't dissolve so quickly that it can't knit together. I think more important is what you do after you've had the cesarean section, not the type of stitches that are used. Very good, very good. Oh, yeah. Nice to see you. All right. Thank you for the webinar. Very interesting. Thank you, thank you. Thank you, thank you. All good, Ollie. It's been recorded. Ollie is in Italy. She's done work with me. She's done the female athlete with me. She's a fantastic person to know. She speaks many different languages. I'm not sure if Greek is in your list of languages, Ollie, but nice to see you. Are there any other questions? You can click the hand up or
they can unmute themselves. I gave them the access to do so.
You did the unmute? Okay. All right. Very brave, very brave. I'm here to answer questions. If you need to know, it's if you need to leave, you can leave, and this is being recorded still. So I'm sure that the PT Praxis will make it available.
Sure, absolutely.
Ollie.
Can I ask a question, Anthony? Yeah, hi.
Yes.
Good to see you.
Hi. Nice to see
you. There is a new ACM guideline that has been just published about the exercise testing and prescription for exercise professionals. So not just exercise professionals, like everyone. And I was reading the pregnancy and the postpartum part, and they advised for pregnant people who have diastasis not to do pelvic floor exercise. Same in the postpartum period. So it was quite shocking to me to see this. And I'm kind of talking to a lot of different... I have posted on your Facebook group as well. So if you would like to chime in there as well. Yeah, grow on your answer. So I think we should... it's a great conversation to have. And what do you think about it? I don't know, maybe now from the top of your head, you probably haven't read it yet, so you don't have even the references they have. But just I
can tell you what I think.
Yeah, thanks.
I can tell you what I think straight away. Number one, to say that somebody has diastasis and not to do a pelvic floor exercise seems silly to me, because what if they need to do a pelvic floor exercise? I think just guessing is not helpful. Now, we also know that if you have the risk factors for having a levator avulsion and you do pelvic floor muscle exercises, you might actually make your levator avulsion worse. We also know this is indicated in the research. So, I think at the end of the day, an individualized approach is needed. If somebody doesn't have any pelvic floor symptoms like incontinence, if they don't have any like urinary retention, constipation, like if they don't have any issues, it's nice to know that you can contract it. It's nice to actually know how strongly you can contract it. But, it's better to know from a professional to tell you where you're at. And I think this is more responsible. But in general, I would never be so brave as to say don't do pelvic floor exercises, especially if, if I don't know. I don't know. I will always say you should check with an internal pelvic health PT. And if you don't want an internal examination, an external examination can be fine as well.
Just to add to this, the reasoning was just because during pelvic floor muscle exercises, because they work so synergistically with the TVA, and so all the drawing maneuvers and the TVA activation would widen the IRD. That was their reason.
No.
Yeah, so I was shocked. Okay, thanks.
Look, okay, so transversus abdominis, I'll tell you a few things that I found. Number one, people to get a pelvic floor contraction will often bear down a little bit to get a reflex contraction of the pelvic floor. So they think they're isolating a pelvic floor contraction, but they start it with their breath or an abdominal contraction. This sends pressure down, and then their pelvic floor works. And so if you've got a therapist that's particularly skilled and thoughtful, they will notice that they generate pressure to get the contraction. Okay, that's number one. Number two, just because the transversus pulls sideways doesn't mean that on a pelvic floor contraction, you're going to widen the diastasis. That's absolutely ridiculous. Because do you know how far you have to pull your transversus sideways before you're pulling on the linea alba? It's just silly. Now, I am somebody who has been fighting for 15 years or more about stopping this idea about transversus. It's never made sense to me that transversus will close the diastasis. You're pulling something apart. How is this meant to bring it together? It never makes sense to me. I think rectus training is important, but to say that a pelvic floor contraction is going to activate your transversus too much and pull apart a diastasis, you might as well say, please don't breathe out because you might blow the candle out that's in the next room. Okay? That's how silly it sounds to me. So, I don't know. You got me on a good one, Ollie. That annoyed me.
If I may add something here, Ali and Antony, I think that, and I agree with Antony on the fact that and most of the women who come to us, they request to check their pelvic floor. So they say, are you going to check my pelvic floor? Because they want to know if it's working. Of course it's working, and again, you take away the fear, but the internal exam, it's good to reduce the risk. It's good for them to know how to reactivate it, because if they cannot really contract it, that doesn't mean it's not there. You can really help them to remember it and bring it up to the surface and start using it, because that's an important part of our body. So, we have a prevention and a reducing the risk kind of thing when we do the internal exam. And remember, we want to enter, these women became mothers and eventually they're going to enter menopause. So why not know what's going on in their pelvic floor and just, enter that phase of life pretty well educated.
Yes. Yes. And we know that once the hormonal changes occur and the tissue changes occur, this can be an issue. So Evie has Evie? Yeah. Evie has asked a question. Diastasis in the end can be closed. And look, there is no guarantee by anyone that you can close it. Only surgery. And then surgery has its risks. And even that's not a guarantee, because you can still have a recurrence. That's number one. Number two, if you say close a diastasis, does it mean that it's open? And what does open mean? It's just lengthened. So it's stretched. When somebody has surgery, right, and they're in the hospital, we get them to do different exercises and we try to get them to stand up and to walk and things like that. Why? Because we try to get the joints to move in all the different ways. And one of the things we're trying to avoid are muscles shortening, right? What if you overstretch because of your baby, say, and that's why you have a diastasis? well, why can't you shorten these muscles? And how do we do that? Well, think about the gym junkies. We call them gym junkies. I don't know what you call it in Greece, where they go to the gym and they do lots and lots of biceps like this. How do they walk around? They walk around like this. Why? Because they do lots of shortening exercises and they don't do much lengthening exercises, because your muscles look bigger when they're shorter. So they walk around like this. Why don't we do exercises like them so that we get shortened muscles? This is what I've been saying for so long. All right. So yes, we go through all of this on the course. All of these questions we go through. Not only do I tell you, but even better, you get to experience it. You get to feel it. You get to understand it. You get to ask your questions about it. So
what else do you learn in the course in October? What should we expect?
You're going to learn all about the anatomy, including the diaphragm, the rectus, the external obliques, internal obliques. You're going to learn about assessment and management. You're going to see the ultrasound. You're going to see how I do a consult. So all of these things, all the bits and pieces that I do for the assessment, if you're going to do a detailed assessment, and how to put it together in a way that isn't scary, but is actually empowering. So you're going to do a lot of exercise. You're going to do a lot of different fun things. It's going to be a fun time. And you're going to practice on each other. And if we have enough notice, hopefully we can find some people with diastasis that you can practice on too. All right. So someone has asked, thank you for the talk, so helpful. Are no exercises off the table if hard doming can be managed and technique is good within the person's ability? Hope that makes sense. Where do we start or find the right level? There are some people who they like, we call it foot in the door, okay? So there are some people that are very scared of water and they stand very far away from the water, and then they might dip their toes inside the water, and then they might stand ankle deep in the water, and then slowly, cigar, they go into the water, right? Now, other people, they just go jump in the water, they don't know what it is, and then they're going to find out. You can do both ways. You can ask someone to do something very difficult, or you can go the cigar way. But at the end of the day, you have to choose a level. So somebody today, they did an exercise and she said, oh, I'm not very good because I'm not doing it well because I'm shaking. I said, if you're shaking when you do the exercise, I know that it's hard for you, because nobody does a hard exercise without getting tired. When you get tired is when you shake. I think nothing good happens when you're comfortable. Oh, okay, I'm going to do my chest exercises now. I'm just going to do 100 repetitions of this. Now, if I did this every day and then I complain to you and I say, my pecs are not getting bigger when I do this. I've been doing my pecs every day. Why aren't they getting bigger? It's because you're not working hard enough. So you have to work people hard enough. You control the doming and you control the descent. You don't want perineal descent. You want good support for the perineum. And this is what we'll be doing on the course.
Excellent. Thank you, Antony. I don't see any other questions. However, I'm sure there will be lots of them during October seminar. So yes, I've shared the registration links for October seminar. There are 2 links, one in Greek, one in English, for the registration forms. And this is a fantastic opportunity to experience firsthand the concepts and the approach that Antony discussed today. So he's coming to Athens in October 11th, 12th. I just need to say that once somebody submits the registration form, they will receive an email maximum within 2 weeks with further info about the course. So if we don't have any other questions for now, I must thank everyone. Thank you, Antony, for this excellent webinar. Thank you, Mimi and Fotini, for organizing this. It's a great honor to have Antony joining us. Thank you everyone who joined today. There will be a recording. You will receive it and go through it again and again and think about all the discussed points that Antony shared with us today. Thank you again, everyone. Have a wonderful weekend, and hopefully we'll see you in October. Yes, Antony?
I have one more thing. I just remembered. Diane reminded me. I go through and you learn how to write an individualized exercise program with progressions for the person. I think this is important to remember. So yeah, you'll learn how to write a program like I would write a program as well, so that you can program for people and then you can progress them.
Excellent.
Wonderful.
Thank you very much.
Very much. Thank you all. Have a wonderful day. And Athanasia, thank you very much for your lovely work with us.
Thank you.
Thank you.